Another case that demonstrated the importance of coronary access, at least for us, as we were making this shift towards more self-expanding valves, was really the development of FX.
Aiden Raney here with Murmur and D. Great to be back with Matt Summers. He's the director of structural heart for Centera Heart Valve Clinic, and we'll be going through some cases. Matt, take it away.
Thanks for having me, Aiden. And so we have a selection of cases that we've performed in the last couple of years that highlight some important concepts about how we're making valve therapy decisions with regards to TAVR versus SAVR, and feasibility of redo, feasibility of valve and valve TAVR, and also decisions about self-expanding valves versus balloon expandable valves. And certainly at our center, we've seen a little bit more trend towards higher self-expanding valves in patients favoring a hemodynamic result, but that's obviously come with different challenges that we've encountered. And so these cases highlight where we've made some of these decisions, and maybe perhaps we could have made other decisions that would have made our lives easier on the back end, but also how we've navigated some of those therapies in patients, and really how things have morphed at our center into making some of these really important decisions about which valve to use in which patient. This 86-year-old was a patient that had a S3 in 2018 that had degenerated over the course of the prior 6 months. You can see her gradients had went up to over 40, and it was coupled with class 3 symptoms. When I look back on our planning from 2018, you can see sort of how we looked at things. The coronary heights on the left were a little bit low. The sinuses were okay, but really that coronary on the left, we were looking at things like EOAs then. That's why we had it in red here, but it was less of a keen concern than it was about making sure that we didn't have coronary occlusion. And when we look at things now, trying to do the valve and valve or the redo-TAVR for this 86-year-old, we can again draw circles on top of CT scans and quantify those risks to a little bit better degree than we could in 2018, and with a little bit more guidance than we had in 2018. But we were concerned about all the same things here, and it was going to prompt us to do basically Basilica bilaterally and a much more complex procedure. When you look at all the specific things, you can see that TAVR frame still came up above the left main, but that maybe the bioprosthetic leaflet wasn't going to occlude necessarily, but we did have some concerns about VTSTJ as well. And then this is where DOSI has come in. So being able to model that in a much more sophisticated fashion really allowed us to show, that the right coronary artery has a lot of calcification above the coronary that puts it at risk. The left, we do have, entry into the coronaries and the sinus if we can confirm commissural alignment. So going into that procedure and saying, look, we have to be sure that we're commissurally aligned and we're doing all of those steps necessary, but there's still going to be some concerns. And so instead of just doing a, inflow to inflow implant, an SCV and a BAV, and, hoping for the best and knowing that we have some risks and maybe doing a very complex bilateral Basilica, we're talking about, should we deploy a little bit deeper to avoid sinus sequestration? And if we do that cut, is it the evolute skirt going to prevent the benefits of the cut we do in the S3? And we can see that we need commissural alignment. Does that make an S3 and an S3 a less attractive option? Our valve frame is above the coronary, right at the coronary. Is that really going to matter? And are these models really accurate enough to predict the true expansion of the S3? And ultimately, we still made a decision to do bilateral splitting, but we had shortcut available to us. And so these additional tools also lower our treatment threshold when there are any concerns. But I would argue that we went into this case about as well planned as you can possibly go into with the most sophisticated modeling to guide those decisions. And what's unique about this device in particular, the purpose-built device, we did one on Wednesday, and a degenerated sapien as well, is that we can now do those procedures in less than 20-25 minutes and accomplish what we're setting out to do, which is to mitigate the risk of coronary occlusion from leaflets propping up and blocking the coronaries. In this case, we're still using Sentinel in the valve-in-valve with fractures. TE guidance shows 3D NPR, us getting in position. This is the left split here, which I know a lot of people have experience with this, but it's been a remarkable device for us. I think commercially we did our 7th case on Wednesday. We've done it in trifecta. We've done it in 3 Magna E's. We've done it in 2 Sapiens and 1 Evolute as well. And so it's been very beneficial in all those. But we use 3D NPR to make sure that we're splitting at the appropriate distance between commissures and trying to be at the base of the leaflet and get the maximal split, as opposed to the precision we previously had with Basilica, which, as you know, is quite onerous and can be a little bit unpredictable. And so
I don't have any experience with this, but would you say, if you didn't have this, would you send it to somebody who did? Or try Basilica? I mean, is it that game changer, or where do you stand on your experience so far?
On shortcut?
Yep.
Yeah, I think we do unicorns and cleaves and leaflet modification of that sort when they don't qualify for shortcut. There's still some anatomic reasons, ascending aortic anatomy and angles that sometimes prohibit it. And of course, it's only on label for valve and valves. And so when we get natives, it becomes a bigger issue. The hemodynamic effects of even a double split are minimal in our small denominator of cases versus, as you know, a unicorn or a cleave, especially in a native, you can get a lot of hemodynamic issues with that AI. But I would say that if this is available, it's a purpose-built device. You go through your TAVR sheath, you maintain your Safari wire, you're right there ready to put a TAVR in immediately after the splits. And instead of, you remember Doppio cases where you would snare and create your flying V, then go to the other side, snare, create your flying V, 2 large bore access sites, and then cut both at once. This is a push down. You've got your angles, you lacerate, you turn it, push down, lacerate. Every one of these 7 cases has been less than 30 minutes from start to stop. And we're getting accurate cuts demonstrated by TEE and getting no issues with the coronary. So it's having a purpose-built device that goes over your TAVR wire and through your TAVR sheath to deal with both leaflets is incredible.
And less hemodynamic, less sick too. Wow.
Way less.
Yeah.
And so when we look at this, we had good coronary filling. We had a peak-to-peak of 4. And we did implant a little bit on the low side based on some of those concerns with sinus sequestration, but ended up getting a good result.
Amazing. Great case.
And so I have some other cases here, Aiden, just as far as that have demonstrated some of these decisions we've made historically and how we make them now. In this particular, and we don't have to include all these, obviously, but just so we have it available for you all. This is a 49-year-old gentleman that my colleague, Dr. Kemp, did a Magna E's on, a 23 Magna E's on in 2017 for endocarditis, manifested severe AI. And then by 2022, that valve had worn down. Didn't have any evidence of PVE, but did have symptomatic severe stenosis of his bioprosthetic valve, had patent cores, and had been cleaned from IV drug use, but was getting worked up for another valve. At this time, the decision was made to do a valve-in-valve TAVR with BVF, given the small size. Then we were thinking a tissue valve is a tissue valve is a tissue valve. He wasn't going to be compliant. We were still concerned about adherence with Coumadin for mechanical valve, and we could get him through with the Sapien. And we did get a very nice immediate result. We were a little bit concerned about the coronary heights, and so made that decision for valve-in-valve with an S3 and did a fracture, which was successful and ended up with a low gradient. You can see there, fracture. But then on post-op day 1, even though we had a gradient of less than 10 leaving the room, he had a gradient of 14 with peak velocity of 3 on post-op day 1. And by 1 month, had a mean gradient of 45. We started getting concerned with the valve-in-valve that he was having some HALTs or some other issues, started empiric DOAC, And then 6 months later, his symptoms progressed. His gradient was up to 60, and he ended up finally getting an onyx and a root, and this was his explant visualization. So he ended up getting fibrosis and calcification that early on after his valve, and ended up getting mechanical. He's doing fine, but there was evidence of HALT and pannus formation on that valve already, and this is sort of guided a lot of our concerns about hemodynamics being important. This is an extreme example, obviously, a valve-in-valve inside a smaller one that we ended up pretty aggressively dilating and fracking afterwards. But the take home for us in this case was that the hemodynamics really do matter. This is an anecdote again, but it was curtailing and buttressing next to what we had available data for 20 and 23s through SMART trial, and in a more extreme example with a valve-in-valve. But this is really, I think this is the last valve-in-valve we did with a SAPIEN. And then the question comes up of whether this phenomenon PPM occurs in larger valves. This was a 53-year-old gentleman that had a bicuspid valve, and he was in the bicuspid registry for one of the clinical trials. You can see his bicuspid anatomy there. He's got large sinuses. He's got a little bit of an aortopathy, but it was below thresholds for definitive surgical repair. And this guy was really keen to avoid sternotomy, like a lot of our patients, and had all the options laid out to him, and he wanted to participate. We wanted to enroll him in the bicuspid registry for SAPIEN. He ended up getting a very nice result. You can see we had EOAs of 0.83, so intermediate risk at that point in time. It was a somewhat horizontal aorta, so it was nice to have the SAPIEN there. But he ended up getting a very nice result with his S3. And then again, on post-op day 1, he had some increased gradients. By 1 month, they were trending up again. His aorta was enlarging as well. And then 2 years post, he ended up having mean gradients in the 40s, again, a peak velocity over 4, DI that was significant, and had really fusion from his commissures in, and some of this pinwheeling that happened as we overinflated his SAPIEN valve. And so he had added volume to that S3. And the question was this really PPM or not? I mean, it's hard to argue that it was PPM. It certainly can happen in larger valves. But I think it more speaks to the fact that really these patients under the age of 65, especially with annular eccentricity, the type 0 bicuspids, a lot of them really are better served with surgery as an upfront approach. And I think that's what's being borne out with a lot of the data on TAVR and patients under the age of 65. But this is kind of a demonstration of what we see in individual cases where we had previously pushed the needle of using valves and bicuspids at young ages through registries. But this is a specific example of where we started to see some of these increased gradients over the course of the first month even, but then manifested at the 4 to 5 year time frame as degeneration.
Yeah, no, I think that's, the valve has to be well expanded, and we've got all that calcium there. If it's not well expanded in a circular manner, then you may see early deterioration, any valve. So
exactly.
Yeah, I agree. So I think, I do not push for surgery. I mean, for TAVR on younger patients with bicuspids. It's, I think there's a lot to be learned there.
Yeah, as we get new valve designs, I'm sure that things will swing that way necessarily. It's earlier generations of valves being used.
Sure.
And really centered.
Yep.
Sure. In the mindset when we were pushing the needle towards younger patients.
Sure.
As far as coronary access, this one highlighted, this is a patient that came back to me on STEMI after we went through a very onerous process of valve-in-valve TAVR. It was a 67-year-old gentleman that was consult for us for severe prosthetic AS and left main coronary disease. He had a 23 magna E's in 2016 and then developed a severe post-bioprosthetic SAVR PVL adjacent to his left main. And so underwent a redo and got a magna E's again with a root enlargement in 2017, but still ended up with a 23 magna E's. He had severe COPD, had 2 sternotomies, was still smoking, he had above the knee amputation. So he was 67 by age only, but clearly not a candidate for another redo. He had come in with decompensated heart failure. His EF was now 35% with still high gradient, peak velocity 4.2. He had calcified left main bifurcation disease, a prior circ stent, and he also had an anomalous right from his left cusp. And so his CT, of course, showed low coronary heights, a narrow VTC and a narrow VTSTJ. And so very, very complex. You can see how low his coronaries are. We need to do left main bifurcation stenting, which I did on tandem heart because of his low EF, because it was going to be left main bifurcation stenting. And I ended up putting in an S3 valve because I was worried about coronary access issues later. And so I ended up lasering that circ stent and doing a DK crush with a left main into LID lithotripsy. Ended up getting a very nice result. We did left Basilica because the anomalous right, which was fed by that same sinus, was also at risk. I wire protected that and pre-positioned a stent because I wasn't sure that the Basilica itself was going to protect the right. And so this patient, you can see the work that went through tandem heart, left Basilica, RCA protecting, did a valve-in-valve TAVR, and then fracked with a 24 true. And this guy did great. But then a year and a half later, he came back to me when I was on STEMI call with an anterior STEMI.
Oh, man.
And so you can see that even though we had addressed or tried in our best to address those coronary concerns, I didn't have commissural alignment with the second valve because we weren't guaranteed that. And you can see that trying to get into his coronaries, I could not get through the actual struts. It would only direct me to that right coronary, that anomalous right. And so I actually had to come top down, balloon track in my guide extension into the sinus, which you can see in the upper right there, and then wire from the outside. And you can see just that demonstration of the stent trying to get down to the LAD. How difficult it was. And so this one really highlighted to me that my decisions previously to do low frame valves didn't necessarily, didn't keep coronary access issues, of course, out of the woods entirely. You can still have these issues, and the commissural alignment was really probably arguably the most important thing in a case like this, where you had 2 coronaries coming from that left sinus that was low. And if you draw a direct line between the decisions that were made, I think maybe his second valve should have been a true Bentall or something of that sort that would have prevented a lot of these downstream effects. He ended up doing very well after this, but it highlighted to me that it's not as easy as just saying, we'll use a low frame valve and we'll be assured of coronary reaccess in the future, because that was not the case in the throes of an anterior STEMI.
Yeah. Wow. Well, great case. Beautiful result on the first case. Sorry you had to come back and touch up your beautiful work, but it's you get surprised by these cases sometimes, and despite all your good work, it's bad things can happen.
Another case that demonstrated the importance of coronary access, at least for us as we were making this shift towards more self-expanding valves, was really the development of FX, where we can ensure commissural alignment now with FX Plus, the larger cell to intervene through. So this was an FX Plus, but it was a patient that had trifurcation left main disease and severe aortic stenosis, and was not a surgical candidate by any means. And so the decision was made to do concomitant TAVR and left main intervention instead of, like that last case I showed, where we have to have support and do trifurcation stenting on someone with severe AS, or do a balloon and risk that, and then put an impella in and do things. We said, look, the driving factor of his hemodynamic issues really is the AS. We're going to do TAVR first, and then we're so comfortable engaging through these cells that we're also going to fix his coronaries while he's then and there under anesthesia and with support on standby should it be needed. And so
that's bold.
Yeah.
But you feel comfortable doing that now?
Yeah.
Yeah. Great.
So this is the index. You can see the degree of stenosis in that ramus and circ, and coronary access, of course, was not terribly complex as far as engaging, which you saw, but the decision to intervene through there and how we were going to technically intervene through there was a little bit more difficult. Ultimately ended up cullotting the LAD and circ and then T-stenting that ramus and used lithotripsy, but that was all through a fresh TAVR. And so
Wow.
the
Great result.
decision there is obviously, as we get more and more complex patients that have combined coronary disease,
Sure.
I know this comes up for you. Are we going to tackle a left main intervention? Are we going to do that first? Are we going to do that 30 days? The patient has a low EF. Are you okay waiting 30 days? Are you going to do that through a fresh TAVR? You're going to let that TAVR, let them recover from 4 to 6 weeks or 3 months, but then have someone walking around with left main disease. All these decisions are becoming more and more prevalent in our system, and we're having to make decisions about which valve we're going to choose based on a lot of those concomitant coronary issues.
Yeah, no, I totally agree. I think, before we would fix all the coronaries, we thought that had to be done before a TAVR. I think it's, then you're doing Impella, valvuloplasty, a big project. And I think the opposite is true. So having, coronary reaccess is really important because I agree. I think almost everyone, you can do the TAVR first. That's the most important hemodynamic aspect, and then go after the coronaries. So great case.
And then one of the last things that we've seen is this concept of horizontal aorta. It's far easier to do with the SAPIEN and being able to flex and drive that across the horizontal aorta. I would say now that we have Navitor, we're basically making the decision for most of these valves that are horizontal if we still see hemodynamic differences, or if we have concerns about annular rupture or annular issues with the SAPIEN. We're defaulting towards a more flexible catheter, which is currently the Navitor valve. But this highlighted the degree in which we believed in the hemodynamic issues, the hemodynamic effects of an evolute, is that we're no longer using that horizontal aorta as a determining factor of SAPIEN versus evolute, because we're comfortable doing things like snaring a nose cone and bringing that across the valve. So in this one, the inflow was above the outflow, and we still ended up getting a very nice result. This patient is now a year out, has a mean gradient of 6, did not get a pacemaker. And so a summary of all of this is really that, at least at our center, where we're taking care of a lot of patients with a lot of comorbidities, but we're also taking care of increasingly younger patients that don't want sternotomies. The hemodynamics are guiding a lot of our decisions. It hasn't just been the small annuli, and it's not just decisions on TAVR versus SAVR, although those initial decisions are very important, as you saw with some of the ones that I got it wrong on as far as valve therapy disposition on the front end. But that's really morphed into a shift from 45% self-expanding valves to now 85%. What we're seeing in practice is that we have less interval visits, less empiric anticoagulation for HALT, with things like cusp overlap and high implants. Our pacemaker rate and length of stays have been marginally affected. Certainly that'll always be a differentiator between the two valves. I work at a place where we have incredible EP docs that do left bundle pacing and are part of a very strong extraction program. So arguably the parachute I have, so to speak, for tolerance of some of those things is less or is more. But we're not seeing a huge impact from patients that end up having a slightly higher pacemaker rate that get a physiologic pacer compared to prior. And we're seeing that offset for sure by the hemodynamic benefits of some of these patients in the early term. I think coronary commissural alignment is arguably the most important thing that we've noticed as far as coronary access. That this annular eccentricity, which I know is a hot topic right now, may lead to early degeneration, especially in bicuspids in younger patients. And that in our experience, arguably that you can treat almost all patients with self-expanding valve. I do think it requires us to individualize that approach with each patient. And obviously, if you have horizontal aortas and bicuspids of that sort, and you get a good 29S3 in, I don't think there's any penalty for those. But at least at our center, what we're really preferencing things towards is trying to get the best hemodynamic result at the end of the case, and not necessarily choosing the valves based on what is easier to put in or that's technically different to put in, but more on the patient specific factors that we think are going to be at risk during a case, whether it be annular rupture or coronary occlusion risk or PVL risk and things of that sort. We've coupled with more precise pre-procedural modeling to make a lot of those decisions. And so if I'm trying to make the right therapy decision, I'm trying to pick based on the likelihood of and risk of a second intervention. Arguably, we're still at the point in time where a lot of patients don't outlive their first valve, whether it be SAVR or TAVR, but that will increasingly be a problem. We've really at our center preferenced patients under the age of 65, particularly with type zeros or abnormal bicuspid anatomy or eccentric anatomy. That surgery really, the bar for a TAVR should be quite a bit higher than it was historically. And then we're trying to pick really by each patient which valve, the best valve first, not necessarily like we were in the past, which is which valve would allow for, say, a perception of a safer reintervention in the future should that valve wear out. I think we're seeing that hemodynamics matter as far as BVD, and then we do think that those are going to lead to differences in outcomes, but although we're all going to find that out in the next several years. We do know that hemodynamics tend to lead towards better durability in some of the early data. And then really the consequences of being wrong on some of these decisions, which I worry about, shifting volumes in one way or another and hitching my cart to the wrong horse, so to speak, is that, what are the consequences if we aren't interpreting this data correctly, if things swing back the other way and really the hemodynamics don't matter quite as much as we think they do. And honestly, when I look at those, the consequences are really what am I going to be able to do if we're wrong for a reintervention? And I think increasingly we're getting comfortable with VEV and SCV implants, that this leaflet overhang may not matter really much at all, that most patients are able and capable of having a node 4 or 5 implants. Commissural alignment is really the most important things. Really third valves, if we're picking patients under the age of 65 for SAVR and doing a very straightforward, especially if there's a root enlargement, a big valve, doing this very safe valve-in-valve TAVR in their late 70s or 80s, how many of those patients really outlive those 2 valves, I think is going to be the next question. I think third valve is rarely necessary now. I don't know how necessary it's going to be in the future unless we're making some of these decisions on the front end that don't pan out to be correct.
Right. Awesome, Matt. Well, thank you so much for coming on. Really appreciate your perspective on all this, and it's been great to hear from you.
Absolutely. It's nice to be involved, and it's great to talk with you.